that introduction again. And for those of you who were here earlier today, hello again. I'm getting used to this. I've been told when I was moving around before, sometimes I was in the dark, so they've put all these extra lights on to light me up and told me to, you know, get used to it like Madonna does. So if I fall off the stage, I'm just doing my Madonna impression. So Candy asked me for this special second talk to talk about making the invisible visible. And I was part of a group that presented this document to the European Parliament in Brussels in 2013. And it was a group that was put together because we were all very motivated and driven practitioners who for many years have become increasingly frustrated about the fact that ADHD is just not on the radar politically. And certainly in the UK, that's something that we've found. I work in forensic services, and a little while ago, a few years back, not that long ago, about 2 or 3 years ago, a politician called Lord Bradley in the House of Lords was asked to do a review of the provision for mental health services in our prisons. And he did this report. And this report is called the Bradley Report. It's got a proper title, but everyone calls it the Bradley Report. And this report just covers everything about mental health, including neurodevelopmental disorders. There's lots of stuff in there about autistic spectrum disorder and learning disability, but there was nothing in there about ADHD. And I know, because of all the research I've been doing, that how many people are in the prisons with ADHD, and I felt quite cross about this, so I went to see him at the House of Lords. And when he speaks, he actually says that he met this woman called Susie Young who told him off and took him to task. And actually, he's been very helpful with helping us to get this on the agenda. But that was my experience from the UK, and other colleagues in other countries are having similar experiences. So ADHD Making the Invisible Visible was put together by a group of people from across Europe. It's co-authored by, I'm the lead author, but it's co-authored by Michael Fitzgerald from Ireland and Martin Posma from the Netherlands. And I do have to say that it was sponsored and funded by Shire Pharmaceuticals. And I do have to disclose that in driving this initiative forward. A lot of people criticize the pharmaceutical industry and involvement in this kind of work. And the only thing I can say is one has to question where we would be sometimes without it. I'm a psychologist, so they can't influence my prescribing practice because I don't prescribe. But I think we are in an era, we are in today's society where for ADHD, certainly all the educational materials, everything that's provided about ADHD is coming from the pharmaceutical industry. They do have compliance regulations. They have to meet certain compliance, criteria. But a lot of what they're providing is very informative and very helpful. And without it, we would not have this information, these excellent booklets to hand over, to give to our patients and the information. Most of the training in the UK is funded by pharma industry. So, we can't live without it and we can't live with it. So we have to kind of do the best we can. This was put together, though, because, as it says here, ADHD doesn't feature highly on the current national and EU policy agendas. And this is in spite of accumulating evidence of a substantial impact on individuals, families, and society. The Whitepaper project, as it says down here, was initiated, as I've just said, and funded by Shire, but it was also supported by the European Brain Council and Gamian Europe. Gamian Europe being the Global Alliance of Mental Illness Advocacy Networks, and it had strong input from the user support networks. You can actually download the white paper. This at the top here is my personal website, and on there we have lots of resources, and the resources include this white paper. You can also get it from the European Brain Council's website and other websites, but you can actually download it from there along with lots of other resources that we have on there, free resources, plus there's a lot more coming, so keep an eye on it. So the aim was for this to be a lobby to put the information to the European Parliament. We've been very successful in the UK in lobbying the Parliament, our Parliament there. We have actually we've seen in the education bill that went through Parliament, where the changes to the education of our children, changes to the bill about certain changes that were made to that bill. And we actually got ADHD in that bill, because again, it was something that you get autism mentioned, you get learning disability, everything. ADHD is always missing. It's invisible. And that's why we called this Making the Invisible Visible. And it has since been rolled out across Europe. So what the white paper looks like is it, first of all, has a chapter about the burden of ADHD. About the difficulty for the individual and for their family and for society. Then there's a whole chapter reporting studies on the impact, the costs, and the long-term outcomes of ADHD. And I was particularly involved in the third one, in the long-term outcomes of ADHD. And then thirdly, the white paper summarizes recommendations for local, national, and European stakeholders, and concludes with a framework of action for a suggested way forward. The background and the whole drafting process was started in November 2012, when there was an expert roundtable with people from all over Europe. There were presentations and discussions and sharing of ideas and experiences in our different countries. And from that, we got some outcomes, and these served as the input for the expert white paper. And as I said, it was developed by myself, Michael Fitzgerald, and Martin Posma. And it included the formulation and a set of concrete policy recommendations that we hope that people would look at and draw on and start to roll out, doing what they can in their own countries. And it caused quite a big splash in the media as well. And certainly in Spain, it was launched in Madrid, and it attracted a lot of media attention there. Also, we had additional input and examples of good practice provided by a number of stakeholders. So once it was developed and started to be outlined, it was sent out to a variety of stakeholders, people, representatives from mental health, from education, from the workplace and the criminal justice system, where people added added information and extended and helped us to shape the final document. And that should also include service users. So our objectives were to increase awareness and understanding of ADHD, including the latest facts and figures. Of course, we're 2 years on now, so as I go through this, I'm going to supplement what I'm going to show you with some of the more recent information. And we wanted to propose concrete policy solutions to address the societal impact, the costs, and the long-term outcomes in support of affected individuals. So the first chapter is the introduction to it, and it starts, we have this nice diagram showing you've got an inattentive type, you've got a hyperactive impulsive type, and you have the combined type. And it's a very visually nice document, actually, because it's got lots of illustrations like this one on the top, showing that it affects approximately 1 in 20 children and adolescents across Europe. I mean, what that probably means is that, I suppose it depends how long the street is that you live in. But in everybody's immediate vicinity, there's probably one child with ADHD. In every class, there's going to be at least one child with ADHD. It talks and describes, as much as I talked this morning, about the very negative impact in children, about their problems with their social functioning, problems with their academic achievement, and their psychological well-being. And for those of you who were here earlier, you heard me talk about this in more detail. But young people become adults, and I also talked earlier about how important it is that ADHD is considered as a lifespan condition. This is something that, doesn't go away. People don't wake up on their 16th birthday and that's it, it's done. It's not like an anxiety disorder that has a natural course that begins and ends. And even if you do, even for those young people who are no longer symptomatic, as they've grown up, their symptoms might get better, but they have all the baggage and all the problems that come with them. All the things that all their experiences, negative feedback from people, all the negative feedback from teachers, from classroom assistants, feeling that, they always have felt different. But having that negative feedback always that reinforces that feeling, being bottom of the class of this, but top of the class of that, why? They don't understand. And people think, well, if you can be top of the class in maths, why are you bottom in the class for English? You can do it. And what often it is, it's about interest and what they want to do and being able to, focus. And there are these patches of things that they can do very, very well if they're very interested. So you've got a lot of all this negativity that's often come with them, not least comparing with their siblings. They feel like they're the bad sheep of the family. Everyone else did okay in my family. They all went to university, but I didn't. I didn't get in. And they're being compared all the time, and they feel that they're not good enough. And the one thing in all the groups that I've run with people with ADHD, they'll all have very different stories to tell. And they all have very different experiences. But the one thing that they all have in common is that they're all underperforming their potential. They're all underperforming in some way. And they all have known for a long time that they're different in some way and that somehow they're not making the grade. That's not a nice feeling to have, even for a little while. And it's a horrible feeling to have for nearly all your life, to grow up that way. So they get to adults, there's a negative impact for the individual, starts to affect their personal relationships with their partners. They have difficulties not just at school, but also in further education. And I think that certainly in the UK, in further education, they're only just starting to wake up and realize and feel that there are students with ADHD in further education, and they need support and help and special attention maybe. They have to find and stay employed. So lots of difficulties here. We know, though, and it's in the introduction, that there are guidelines for the diagnosis and treatment of ADHD. And for those people who don't think it exists, well, we just sort of direct them to that. And there is a lot of evidence to say that effective management can improve quality of life. And for me, this is absolutely key. It's quality of life. I said earlier, who cares if you're 2 or 3 points better on a rating scale for symptoms? What really matters is whether that person has gone out and got a job, whether that person has, not had an argument, not had a violent argument with their partner, for the last month. It's about improving quality of life and having functional outcomes. So the second chapter is really presenting the data. And these are the studies that were done by myself, by Michael Fitzgerald and Martin Posma on the impact, the costs, and the long-term outcomes of ADHD. And these 3 studies relate to, the first one is the Lifetime Impairment Survey, which Michael Fitzgerald led. The second is the Cost of Illness Studies, which Martin Posma led. And the next one is the Long-Term Outcome Study, which I led, which I was involved in. So if we look at the Lifetime Impairment Survey, first of all, this was a survey that was done all over Europe, and it went out through the support groups across Europe to establish the degree to which ADHD impacts children's lives. And we wanted to know what the areas of life were most affected by this disorder. And this figure is the percentage of parents or carers who were reporting a strong or moderate negative impact on various aspects of their children's lives. So they were reporting sort of, moderate to strong impact on their lives. And 45%, actually this is I'd have to stand this way to read this. So it's about 42% had negative impact at school, slightly lower on daily life and activities, social life, life at home, relationship with friends and classmates, relationship with siblings, and relationship with parents. To be perfectly honest, I was actually quite encouraged by this, that you've got about 23% who, so you've probably got 3/4 were not reporting a strong and negative impact with parents. I was really quite pleased about that, because I think parenting is so important. The relationship with parents and how they help them and guide children is very, very important. Relationship with siblings wasn't so bad, but so also you can see, but still means that around 1/4 of them were saying that there was a negative impact with siblings and with parents. But turn it on its head and you can say, well, it's not all doom and gloom here, okay? That's me trying to put a positive spin on it, because I'm an optimist. And I like to find ways that we can work with people. And when I work with people with ADHD, because it can seem a bit doom and gloom when you look at all the outcomes. And what I've found is what's so important is to find something that they can achieve, find something they're good at, find something they can learn to achieve. Most young people with ADHD don't know what it's like to achieve. They've got lots and lots of projects that they start and lots that are never finished. So they've got lots of stuff all around them, and it's like having lots of spinning plates in the air. And they don't know what it's so nice, isn't it, when you get something done and you have a list of things and you can tick it off or cross it out because you've done it. That's a sense of achievement, and they don't know what that feels like. So it's about engaging with them and finding something that they're really good at and working with that, getting them to focus just on that, whether it's playing the drums, reading, whatever, but get them to focus just on that, to do something really well, to get that sense of achievement, to know what that feels like, and then get them to start learning how to do that with other areas of their life. So I try to be an optimist, but the fact is, I suppose, that we do have to look at these figures and say, there is an awful lot of impairment going on here with young people with ADHD. Some of you saw this slide earlier. If we look at the academic outcomes, this is not in the white paper. I'm drawing on other work here. But American study looked at children with ADHD compared with children without ADHD. and found that they had a lot of, there was reading disability. Around half of them had that, whether they were boys or girls. Slightly higher percentage for written language problems, again, whether you're boys or girls, compared to young people without ADHD. This is data that a colleague of mine has got, and it came from the adult ADHD, it came from ADIS, the adult ADHD main service user support group in the UK, with a survey that they did that reported that 39% of young people with ADHD were actually excluded from school. So if you're out of school, you can't really learn very much because you're excluded from school for some reason. And of those, 11% are permanently excluded from school, so they are out of the education, out of mainstream education, and they're going into some other form of educational facility, and the stigma that perhaps that might bring. As a group in the UK called the Better Futures Group, we felt, when we were lobbying the UK Parliament, we felt, at what point do you intervene? Where are we going to intervene in this process? What do we recommend? And we recommended that at second fixed-term school exclusion, not the first, but the second time a child is excluded from school, that this should trigger something to happen. And what should happen? Well, we said, well, maybe teachers, parents, somebody should think we need to look a bit more closely at this child. And what do you do? Well, we suggested the Strengths and Difficulties questionnaire because it's free, it's on the internet, it's downloadable, it's in loads of different languages, it's validated all over the world. So we recommended the Strengths and Difficulties questionnaire is used to help assess the child. And it's something that teachers can do. All the information is on the internet. So we recommended at second fixed-term exclusion that this triggers something. Because you could intervene at any age, but intervention isn't prevention. And if we want to change the trajectories, we have to intervene earlier, and our aim has to be prevention. And in our lobbying, in the educational bill that I mentioned earlier in the UK, from our lobbying and that of other groups as well, they've taken that on board, and we have in the bill that at second fixed-term exclusion from school, this should trigger some kind of assessment. Well, occupational outcomes as well, as they get older, thinking about as they're moving along the trajectory, there's problems there as well. This was from clinic data from the Maudsley Hospital. So if you have ADHD, out of the people coming to our clinic, we found 44% were unemployed and 13% of them were students. If you fell below the threshold of a full diagnostic classification, which when we did this was DSM-4, so if you were, we called it in partial remission, 40%, similar rates, 40% were still were unemployed, but a few more were in education. 21% were students. So it doesn't really matter whether you've got a diagnosis of ADHD or whether you're starting to remit from your symptoms, it's still affecting your employment, the likelihood you'll be employed. Probably because although you're remitting from your symptoms with ADHD, but you still have some kind of associated impairment that's causing a problem in you getting a job. But more are going into students, and what I thought was good was if you're fully remitted. So for those people we were assessing who we felt didn't have ADHD anymore, but they'd had a history of ADHD from childhood. This is an adult clinic. Had a history of ADHD from childhood. 22% of them were unemployed, but 44% were students. And if we compare this to control data, we had 3% unemployed and 30% in students. So it kind of looks like there is an opportunity somewhere around here where people are catching up with the educational opportunities that they've missed. But still a quarter of them nearly are unemployed, even though they have a childhood history of ADHD, they're not considered to be symptomatic anymore. See what I mean about the baggage? And that, as a quarter, that's too high. 22% is too high. Now there's a title to grab your attention, isn't it? ADHD, a deadly disorder. I can't claim the title. It was a colleague of mine that wrote about it and called it that, Steve Ferroni, when this paper came out very recently from Søren Dalsgaard. And it's data from the Danish registry. It's published in the Lancet. I'm sure some of you might have heard about it. It's caused a bit of a splash. It's data from the Danish national registers. And in the Danish national registers, they followed up, they had 1.92 million people, just over 32,000 of whom had ADHD. And what they found, they looked at the mortality rate of these groups. And they found that if you didn't have ADHD, the mortality rate was 2.21%. And if you had ADHD, the mortality rate was 5.85. Much larger mortality rate. When they work it out as a ratio, it comes to 2.07, so twice as much. Now, the most common cause of death amongst the ADHD group was accidents. Like 77.8% of all the unnatural deaths were accidents, accidental deaths. We've been reading for quite a long time about accidents with ADHD, but nobody, I think, really realized fully, really appreciated what this really meant until this paper came out last week. They also calculated the mortality rate ratios when they adjusted for calendar year, age, sex, family history of psychiatric disorders, maternal and paternal age, parental education and employment status. So they adjusted for all sorts of things when they looked at this data. And they still found a mortality rate ratio of 1.5. So still a lot more, still much more significant. What was quite astonishing, though, was the mortality rate ratio in adulthood, because what they did is they looked at the age of the individuals. And they found that the mortality rate ratio was much higher if you were diagnosed in adulthood. So, for example, if you were diagnosed before the age of 6, with all the adjustments and everything they did, it's quite a complex paper actually, but with all the adjustments, the mortality rate ratio was 1.86. If you were diagnosed between the age of 6 and 17, the mortality rate ratio was 1.58. If you were diagnosed when you were 18 or older, the mortality rate was 4.25. So I think that what this shows us is the risk of having ADHD and not receiving treatment for it. So it's a new paper, so I had to make some notes because I didn't have those figures in my head. So the next part of the chapter is all about the cost of illness studies that Martin Posner led. And he looked at, there were only 7 published econometric studies on the costs of ADHD in Europe. Not very much. given that we're a whole society that's driven by money and funding and in the UK we even have something called payment by results. Have you heard of that? Do you have anything like that? We have our health services are receiving funding based on the results that we provide, the result, and they're being evaluated on that. It's called payment by results. As you can imagine, it's not very popular. So, what Martin found when looking at this data is that there are considerable costs associated with ADHD that were attributed both to the patient and their family members. And these studies are shown in the document, and you can download it. But what I think for me what was more important was what wasn't there, was the data that wasn't available, rather than the data that was available. Because data on costs associated with education, productivity loss, social services, road traffic accidents, criminal justice system, this kind of stuff wasn't available. And I was sitting in meetings listening to the findings, and I'm saying, yes, but what about the costs with all of those people who are in prison? What about all these costs? What about, you know, and the costs just weren't there because the data isn't there. Well, again, the Danish have taken this on board, and there's a new report from the Danish about the costs of untreated ADHD in over 19,000 Danish individuals who were diagnosed as adults in 2010. So this is a study of the costs of untreated ADHD. And again, it's it's 2 books. There's no published papers no manuscripts in peer-reviewed journals about this, but it's in books, and you can get them from or maybe it's on the next slide. Is it on that side? Does it say the Rockwell Foundation? Yes. Oh, it's at the bottom. It's down here. It's www.rockwoolfonden.dk. And you can get it from there. But it was a very well done study. I know the people who were involved in it, really meticulously done, again, based on these registries. And what they found, the first one, is about the private costs. These are the costs to the individual of having ADHD. And this is all in Danish million. Krona, million Danish krona, it's to the million. So if they looked at the income, the disposable income, compared to the general population, they have less, but also they did a study, they looked at it compared to their siblings. So they have less income. But they're receiving more because of public transfers were benefits that are paid by the system. Okay, so they have certain incomes, and also included in that were certain education and victim costs, supplementary incomes that they're getting from the government for some reason or another. So altogether, when you take them, you have, in the red, you have a total private cost of much lower compared to the general population and compared to their siblings. Then they looked at the public cost. This is the costs to the government. And again, in Danish krona to the million. And the first one is about what they're losing, if you like, in taxes. Do you know, in income tax and other taxes? What they're paying out to people for in supplementary benefits. And in here as well, in this data here as well, was the crime and traffic accident costs. And again, there's not a lot of black on the figures, is there? It's all red. So again, there's minuses here compared to the general population and compared to their siblings. Public expenses for placements. This is expenditure that's costing in things like putting children into care homes or other kind of similar placements. This is there's costs associated there, both compared to the general population. They're losing money compared to the individuals in the general population and compared to their siblings. No difference with educational expenses. Again, medical expenses, they're costing a bit more, both compared to their siblings and compared to the general population. And if you add this up, you've got this large deficit to public costs compared to the general population and compared to siblings. And then if you put this, they sum it together, and they come with these large figures of the costs of untreated ADHD. And it's high. I don't know what it is, Danish kroner to your currency, to the Swiss franc. But of course, it's all relevant because it depends on the size as well of the country. But what it means, though, is that there are huge costs of untreated ADHD to both the individual, to the family, to government support, and to wider society. But what they did find is that more than half of the costs were paid by the public sector. It's costing the governments, on the government systems, local governments. It's costing them a lot of money not identifying, recognizing, and treating ADHD. And you know, the big contributor, the big driver in these costs was low labour market attachment. And actually that kind of fitted with some of Martin's, in the white paper, some of his data which showed productivity losses. That there was some small data that was showing there was an issue here with productivity. So I think, you know, they can't get a job, so they're supported by the state, for example. Local governments and big governments need to hear this information. They need to know this information because we're in a society where we have to justify everything by costs. I can't think of, and I'm going to show you another one later, but I can't think of a better reason, if for no other reason, if we don't care about treating, say we don't care about conferring health gain for people with ADHD, all right? Just save some money. And here's a big, I've put it down here in larger font for you to access it yourself if you want to read all about it. Right, now to my study, the long-term outcomes study. This was a systematic literature review and analysis to evaluate the long-term outcomes of ADHD and investigate whether they improve with treatment. And I was very interested in this study because, as I said earlier, in a way, it doesn't really matter what somebody does with symptoms. I'm really interested in functional outcomes. And this is what we focused on in this study. So we compared age groups differing from 2 years or more. It makes me feel old, actually, when I'm working with people and they think a long-term outcome is 2 years or more. 2 years isn't very long, is it? But anyway, so in terms of follow-ups, 2 years or more is quite a long time in the ADHD world. And we looked at, there's 2 or 3 studies that are put together here, but in my presentation, but we looked at up to 404 studies on the long-term outcomes for participants with treated ADHD or untreated ADHD. Many of the studies reported more than one outcome, of course. They don't just have one study per outcome. And there were over 600 outcome results analysed, and we classified them by treatment, whether the treatment was pharmacological, non-pharmacological, or combined. It's kind of crude, but we just had to put them in these 3 pots. And the outcomes start with the light one and go round to the dark one. And the largest number of outcomes that are being studied are drug use and addictive behaviour. This here is all the academic outcomes. Here is the antisocial outcomes. This is social functioning. So those are taking up pretty much 3/4 of the interest in terms of outcomes. But we've got new ones coming along too. Interestingly, we've got occupation, self-esteem, driving outcomes. Again, this is the accident theme that's starting to come through in the literature. Service use, and the small one is obesity. Those were the only outcomes at the time. Sometimes people say, why didn't you look at this outcome or that outcome? And it's because when we did this systematic review, those were the outcomes that were there. There were no other outcomes, and we deliberately left out symptom outcomes. Well, first thing I can tell you is that ADHD is a worldwide problem. The yellow line is North America, the green is Europe, the blue is Eastern Asia, and the purple along the bottom are international collaborations. And what this is showing is that there's been a marked rise in studies of long-term outcomes of ADHD published worldwide between 1980 and 2010. So we can see how much is going up here with North America starting, followed by Europe here in the green, and then Eastern Asia starting, didn't really do much, a little bit, and then they're starting, Asia definitely, particularly China, getting quite interested in outcomes. Now there's an interesting country. I was asked to go to China to do some training on CBT. I'm used to doing this with a group of, 20 to 30 people. And I said I'd do it for 20 to 30 people, and I walked into a stadium like this, just like this, full of Chinese people, all watching and listening. And I had to train them, and they all kept going like this, and I had to train them, and I get them to role play, and they were role playing and doing stuff. And what I learned is that even though I couldn't understand a word they were saying, you can see whether somebody's doing something and learning it when you know the material well. And they were doing a particular exercise where a woman is flirting inappropriately with somebody. It's an exercise we have. It's quite a fun exercise. And, everyone flirts the same all over the world. What we are seeing, starting here with this purple line, are international collaborations starting, and I think that's the funding, where the funders are looking much more for groups of expertise and countries to get together and start to answer some of the important questions that we need to answer. So if we look at the outcomes by region, down here, I don't know if you can read them along here at the bottom, these are the outcomes, and the grey bars are showing what the pooled number of outcome results. So that the most of the outcomes, you can see drug and addictive. These are the total number of outcome results as you go down. But if it's just another way of showing that pie chart that I showed you in the last slide. But it's interesting because we can see that in Europe, in the green slide in Europe, we're quite interested in antisocial outcomes. There's the peak there. In North America, they're very interested in substance misuse. In Asia, they're interested in self-esteem, drug use, and antisocial behavior. So different countries have slightly different interests in the outcomes. What is being studied by the different age groups? Well, and I think we would expect what this slide shows. Because, for example, take the blue, the pale blue, the academic, and what this is showing is that when you're children 6 to 12, there's a lot of studies on academics, slightly fewer when you get to adolescence, and even fewer, this is the percentage of studies, when you're an adult. But we're starting to see more here from children to adulthood, more of the drug addictive studies coming, the drug studies coming into play. A lot more studies here, more driving and occupational studies as they get older. So what people are studying is reflecting the age of the group. We wanted to know whether the long-term outcomes of people with ADHD benefit from treatment. And in the first column, first left here, we have untreated ADHD participants compared with non-ADHD. And what this shows is that 74% of long-term outcomes are worse for untreated ADHD. So 74, if you're not treated, 74% of the outcomes are worse. 26% are similar, but a lot are worse if you don't get treated. Here, what happens if we treat them? And if we treat them, you have 72% of long-term outcomes show benefit from treatment. So that's positive, it's encouraging, but and this is any treatment, putting all the treatments in together. But that does mean that 28% are not benefiting from treatment. And that's bad. That's just not good enough. And we need to find ways to address that. We wondered whether the age you get the treatment makes a difference. So when you initiate treatment, does it make any difference? So we divided the studies into the mid-range age at initiation of a treatment. And we've included all the outcomes together here. Most studies were in this group, the 8 to 12-year-old group, with 32 studies. There's only a few studies here, 4 and 5 of the other age groups. What we found, though, was between 60 to 65% of outcomes improve with treatment, regardless of age of initiation. Now, that's really good, because that means it's never too late. You know, there's no sell-by date here on when we intervene. So you can improve outcomes at whatever age you start to treat. The younger age of initiation benefits were self-esteem, social functioning, and academic outcomes. If you were intervening with the older group, the benefits here were leaning towards obesity and drug use. Well, we also wondered about what about persistence of treatment? Are there differences in outcomes with a shorter or longer follow-up? Okay, so is there a difference as to how long you persist in giving treatment? And what this basically shows is that that there's maintenance of benefit is observed over the longer term. So it does follow on into the longer term. Drops off a bit, but it is into the longer term. It's quite good. Well, with treatment, do some outcomes benefit more than others? So this is the outcome, the benefit of outcomes. So you can see from the studies, most improved were driving, obesity, self-esteem, social functioning, and academic. I think the intermediate were, and this one is drugs. The drug use. Intermediate as well is antisocial and service use, 50-50 here, and not very good with occupation. And I mentioned that earlier on, and I think what it is that we need to get the right treatments for occupation. We need to develop good occupational treatments. This is all about effect sizes. Let me put the next thing up. What this is showing is that this is a small effect size, treatment effect. This is a medium treatment effect, and here's a large treatment effect. So everything up there is really good because it's above large, if you like. This is pharmacological treatment. So you can see with pharmacological treatment, we have quite a good treatment effect. This is with non-pharmacological treatment. It's quite good, but not quite as good as this. But look what happens when we combine the two. Look at these treatment effects. Much, much better. And what that means is that combined treatment is the best. These findings held when we did additional analysis that looked at whether at whatever age of initiation treatment was started and also duration of treatment. So it was still combined was the best. So What's the effect of treatment on each outcome domain? Now, I have to say, when we're getting into this level of detail, we're starting to lose a lot of power because I'm getting into smaller numbers. Okay, but here we're dividing up. We're trying to tease out what treatments are best for what outcomes. And the pale blue is pharmacological, the mustard colour is non-pharmacological, and the dark blue is combined treatment. And what this is showing is that self-esteem, social functioning, academics, and antisocial behaviour may respond particularly well to combination treatment. This is this dark blue, and I've put a circle around this antisocial one because I use it often when I'm speaking about offending with ADHD, because I think, I always say complex needs, a complex presentation requires complex treatments. And that means you've got a lot of comorbidity, and you need to have combined treatments to do that. But, as I said, there are a limited number of studies for some outcomes and some treatment modalities. And towards the end here, look, you can see that there are only, some of them only had pharmacological. I will say one thing, the non-pharmacological treatment was a ragbag of all sorts of all sorts of treatments. So it included cognitive behavioral therapy, it included neurofeedback, it included mentalization, it included play therapy, it included all sorts of things. It was a ragbag. And one of the things that I'm familiar with the literature for CBT with adults, and I would be very interested to see this when there's enough data to look at it, to look at CBT, because I think that it would probably be better. The effect sizes would be even better for the pure non-pharmacological. What about the social outcomes? Well, so many of them are moving from classroom to courtroom, and this is really my soapbox, because this is something that I work with a lot and I see an awful lot. We did a study in a police custody suite in the east of London. And we were interested to see who's presenting there ready, who's going to be interviewed by the police. And we found that 7% screened positive for learning disability. That's intellectual disability. 3/4 of them had a conduct disorder. 1/3 screened positive for ADHD, and around 1/4 screened positive for current symptoms of ADHD. We did an adjustment to be conservative, because actually we're using a clinical diagnosis. It was about 22%, but we made an adjustment because not everybody who was screened went on and had the full clinical interview. All right, because people were being released they were being released on bail, and they didn't want to hang around to have a clinical interview with us. So they just wanted to get out of the police station. So personally, I can't understand it. They said they'd do it, but they just wanted to get out. So we did an adjustment here, which came up with 18.5%. Compare that data with the population rates here. So what this is showing, compared to the population rates, is that there's a disproportionately high number of people with developmental disorders who are presenting in police custody suites to be interviewed, who have been arrested and are going to be interviewed by the police. Nearly all of them had comorbid conduct disorder or learning disability. Nearly everyone with ADHD had something else. And actually, we were there. Do you know about the London riots, when we had these huge riots and things were burnt down and shops were smashed? It was absolutely terrible. But we happened to be there when the London riots were there and were going on. And this police station is a very large one, and it's where a lot of the youth are sent there. And the ADHD screening rate increased to 38% for those who were processed in the first 2 weeks following the London riots. And it wasn't significant, but we're talking about, again, about a small sample. But I'm just saying that maybe there are local issues that might go on that people with ADHD get drawn into, get dragged into, are impulsive, think something's a good idea. Yeah, there's a riot, let's go and steal some trainers. You know, like, so they get pulled into something thinking it's a good idea. Right, behaviour in custody. We also wanted to know what happens when they're in custody. And so we looked at the number of requests for food, drink, whatever. You know, in custody there's a bell on the door and they push the bell. They make because they spend a lot of time in their cells. We wanted to know how many times they're pushing that bell and what for. And what we found is that the demand, we called it demanding behaviours, that there were positive correlations with conduct disorder, with ADHD, and of course we controlled for the length of time that they spent in detention. But for every diagnosis, those screening positive made more demands than those screening negative. But when we did multiple regression analysis, we found that it was ADHD followed by alcohol use that was the most powerful predictor of demanding behaviours, even over and above conduct disorder. So it was ADHD that was pushing them to start pushing those buttons. And I think it's because they're restless, they're in a small cell, they need to be active, they need to be doing something, they can't concentrate, they're freaking out, they're getting distressed, and they're acting out, and all they can do is, there's a toilet in the corner, or they can push the bell. I also did a meta-analysis. It was published earlier this year because I wanted to know how many people in our prisons have ADHD, because there's so much data out there that one could almost think everyone in prison has ADHD. And of course, that can't possibly be the case. Even I think it can't possibly be the case. But with the meta-analysis, what we found is that 30% of youths in a youth offending institution had ADHD using a clinical diagnostic interview. And this is a 5-fold increase. 26% of adults in the adult prisons, that's a 10-fold increase above the population rates. Males and females, it was 26% and 18%, but actually there wasn't a significant difference in those rates. They had a younger age of conviction, if the ADHDs. And we also looked to see what treatment was being reported, and nothing. But hardly anything. That these people in the prisons are being diagnosed by the researchers coming in, trying to figure out how many people are in our prisons with ADHD. We don't know about cats yet. That is available in open access in psychological medicine. And this week we've had a second meta-analysis. See down here it says it's in submission. It's not, it's now in press. Again in psychological medicine, and this will be in open access again when it comes out. And we also did a meta-analyse the comorbidity with ADHD in incarcerated samples. And this was interesting. We've got the odds ratios are above here. What this is showing, you've got the ADHD youths, the youth offenders are the paler colour, the adult offenders are the darker colour. And what the only significant one for the youths was mood disorders, here. Nothing else. All the odds ratios were significant for adults compared to non-ADHD inmates. So even though they're adults, there might have been some of them with some conduct disorder symptoms that were still being endorsed, because it was quite hard to get a complete cut-off with the age. We had to take a midpoint of ages. But of course, there's many more children reporting this. But down here, if you look at the personality disorder, it's kind of similar to the CD one. So I think with the adult rates, we're seeing more personality disorder here. But also anxiety disorder, depression, and substance misuse disorder. So the mood disorders in the youths, as they're getting older, they're staying in the prison system, they're revolving door, they're repeat offenders. I'll show you that in a minute. And what's happening is, as they go along, they're collecting more and more mental health problems. it's accumulating. Ooh, taking too much time. Right. It was associated with a higher rate of recidivism, far more total convictions, especially property and violent offences. And heroin, actually, this was data from Aberdeen prison, and we found that heroin was drug use was the best predictor of total convictions. But for violent convictions, ADHD was the best predictor. And that was using official records. We didn't expect that, to be perfectly honest. It's since been replicated in another study that we've done in Iceland. We also looked at critical incidents. These are incidents that occur on the wing. Okay, incidents, and incidents that were recorded in the last 3 months, recorded by prison officers on the wing. And again, they're involved in far more critical incidents. This is the symptomatic group, well, I think you can tell, can't you? It's the red group. Far more critical, aggressive incidents, and especially verbal aggression and severity of aggression, not necessarily frequency of aggression, but severity. So when they do kick off, it's much more severe. People are much more likely to get hurt. And this kind of fits with those of you who were here earlier when I was saying that the behaviors are much more extreme. ADHD is a disorder of extremes. When they'll go to the extreme. They can't put the brakes on. They can't pull it back. What's happening beyond the gates? Well, what happens when, because I think a lot of attention has been paid now to custodial settings and in the prison. And that gives us an opportunity, perhaps, to diagnose and get people started on treatment. But what happens, then they leave prison, and what happens? They've got to be followed up. So we did a survey in our probation services, because nobody really knows what was going on there. We had a very poor response rate, despite having an awful lot of support from the from the probation trust management, who were writing themselves and asking them to participate in the survey. And I think people are just so busy, so worn out that even a short survey, they don't want to complete it. Very few had any training or actually knowledge about ADHD. They thought about 8% of their caseload had ADHD. A colleague of mine, Mariel Sadamu, went into one of the trusts and actually organized and did proper screening in that trust and found that the actual rate was much more likely to be 20%. What the probationers told us, though, is that they did perceive these clients as being people who have specific difficulties. They saw them as having neuropsychological dysfunction, lifestyle problems, compliance problems, not being able to comply with what they were supposed to, with the rules of the court, not being able to comply with their appointments, not being able to comply with requirements of their tariff. And these problems hindered meaningful engagement with the service and with their rehabilitation. They found it difficult to reach them. They described them being difficult to manage due to what we termed as internal processes. So what we meant by that is they were difficult to manage because of the individual's motivation and difficulty with engagement, with the offender's motivation and engagement. But also they described they were difficult to manage because of external processes, because they felt that they just had inadequate or inappropriate interventions. They described feeling at a complete loss as to how to help people with ADHD and how to manage them. It was clear that screening provisions are needed in probation settings together with training for staff. So another registry bit of data from when I'm talking about ADHD in prisons and offenders, is this something that's quite new to you? Is a new way of thinking to you over here? in Switzerland? It is, yeah. Okay, so I'm giving you food for thought here. Medication reduces the risk of criminality. The Swedes looked at their national register of over 25,000 or nearly 26,000 patients with ADHD. And they examined the medication and criminal convictions between a 3-year period, 2006 to 2009. Well, the first thing they found that 37% of males and 15% of females had been convicted of at least one crime. This is national data, right? This is from a registry. This isn't somebody going into a prison and doing a small study. So for those who are circumspect, but take note. What they found, they were very clever. What they did was, because of their registries, they were able to put the offending registry together with the medication registry. And they did these fancy statistics. Please don't ask me to explain it. But they did some fancy statistical procedure that managed to look at an individual when an individual was on medication and off medication. And what that data told them is that when people in Sweden are taking stimulant medication or non-stimulant medication for ADHD, there was a 1/3 reduction in the crime rate for men and 41% for women. Reducing the crime. Can you think of a better item on the political agenda? If I sat opposite a politician and said to him, you know, we're going to have a general election soon, maybe I should go and talk to David Cameron and say, you know, I'll give you something to talk to people about how you can save some money. I mean, these figures speak for themselves. They didn't believe their data. They're very good researchers, these guys. I know them. They didn't quite believe their data, so they reran it. Not for ADHD data, but they reran it with antidepressants and SSRIs, and the effect wasn't there. It only worked for ADHD. So when I'm presenting in the UK these days, because, as I said, we have to think about money, and I've got to think about time, in the criminal justice system, we have the costs of ADHD. So let's think about that in the UK. Let's do the maths. 85,000 people in the prison population in the UK. Estimated prevalence then, if you base it on 25% from the meta-analysis, we've got about 21,000 prisoners. 25% is a conservative figure because the youth rates were 30%, okay? The Swedish study found the crime rate decreased by 36% if they're taking medication. That means there'll be just under 8,000 fewer prisoners with ADHD in custody. That fewer people, that's the average cost per prisoner per year. And that excludes the prison. I'm being conservative. Excludes the prison. I know it's not quite as simple as this. It's very crude. But potential saving of 203 million per year. And offender health is at the bottom of the pile, even with the Bradley report. It's at the bottom of the pile. And I think there's this perception, you know, lock them up, throw away the key. Why do we want to invest money in this? We have better things to do. We want to find a cure for breast cancer. Okay, fair enough. I'm with you with that. I'm going to show you how you can fund that cure for breast cancer. This is how you can fund it, because if you do this for 10 years, you're going to save £2 billion in 10 years. So, you know, food for thought. Okay, I'm going to rush through this last bit. See, I talk too much, don't I? So psychological treatment, some of you saw this earlier. I've developed different programs. The one I talked about, the Orange book earlier, this is a children's group program that I developed. But the R&R2 for ADHD youths and adults is a pro-social competence training program. It's the only one that's been developed specifically for ADHD offenders. And it's a psychological treatment. It's CBT. It's a revised edition of the reasoning and rehabilitation program, which is actually all over the world. It's got a strong evidence, the original R&R has got a strong evidence base showing a 14% reduction in reoffending if it's run in institutionalized settings, and 21% if it's run in community settings. It's 15 sessions, and you have an individual called a PAL. You have coaching sessions, who's a bridge from the group into everyday life, because we don't want people just to do really well in a group and then go home and do what they always do. Okay? There needs to be a bridge to help them transfer the skills that they learn in the groups into their everyday life. And there's also a 3-session booster. This is now being rolled out by the Swedes across Sweden. The Danes have just done it. They're doing a big study. And actually, they're using this and my other book, the Orange Book, which is, we call it the Orange Book. It's not very helpful, is it? It's the Jan Bramman program, which is an individual treatment program that can also be run in groups as well, though. But they're also using R&R2 because this is manualized, so people like it. It's got these modules, a neurocognitive module for attention, memory, impulsiveness, planning. It's got a problem-solving module, emotional control, social skills and values, and critical reasoning. These are the modules, and this is the particular module, the first one, obviously, that's very, very useful for people with ADHD. We did it in individuals with what's classified as dangerous and severe personality disorder. And a lot of them had a history of ADHD, but they didn't have to have a diagnosis of ADHD. And we did this. It's only a small study because we had to stop it because it was the service was decommissioned in the UK. And the DSPD service was decommissioned because these individuals were found to be untreatable. Okay? So we had to stop it. And I didn't think we'd have any effects. But these are the effect sizes in red at the top showing small to medium effect sizes. There's one large one at the end on ADHD symptoms. For social problem solving, for violent attitudes, anger and arousal, and ADHD symptoms. The Icelandics, we've also done it as an RCT in Iceland. And to be honest, I didn't think that this would work because they did it in like the equivalent of adult outpatients. They weren't referred for antisocial behavior. And so I was a little bit nervous about it because the program wasn't devised for this group. And then they came up with all these fantastic large effect sizes at 3-month follow-up for observer-rated clinical global impression, ADHD symptoms, hyperactivity, impulsivity, anxiety, depression, emotional control, antisocial behavior, even though they weren't referred for antisocial. And of course, because so many people with ADHD have got an antisocial tendency, because so many of them have had conduct disorder as children. So maybe it's not antisocial, maybe it's more pro-social competence, okay, rather than antisocial. But, and better social functioning and ADHD symptoms at the end there. We've got more data on that and a larger study, which has pretty much found the same findings. So, what does it all mean? Well, there are consequences. If we don't identify and treat these individuals, their capacity to engage meaningfully in the judicial process is compromised. Okay, that they have to attend court, they have to go through a police interview. There's a lot of misdiagnosis. There's inappropriate treatment and inadequate or lack of a care pathway. If they're not being recognized, they're being recognized perhaps for something they don't have, or they're being misdiagnosed. The primary diagnosis is not being recognized. The consequences are also their capacity to engage and benefit from rehabilitation. You know, they can't do that because their ADHD hasn't been recognized. They can't attend, you know, they're not benefiting from educational programs and occupational programs. There's their behavioral and management problems in prison. That means they have a high number of adjudications. Okay, so they're getting kind of in more trouble while they're in prison. That means that they're less likely to access early release systems. In the UK, you can come out earlier for good behavior. They're revolving door offenders, they're recidivists, and there's a lot of associated cost to society. So ADHD can have a negative and pervasive impact with wide-ranging associated costs in terms of healthcare and other services. There are long-term consequences relating to multiple areas in their life. Without treatment, the long-term outcomes are substantially poorer compared to non-ADHD controls. With treatment, a substantial proportion of long-term outcomes will improve. There's evidence for improvement with each general type of treatment, whether it's pharmacological, non-pharmacological, or combination. Outcomes improve regardless of the age of initiation or duration of treatment, so it's never too late. Larger effect sizes are associated with combination treatment. Domains of self-esteem, social functioning, academics, and antisocial behavior may respond particularly well to combination treatment. And we need to find ways, though, to keep young people with persisting symptoms engaged with our health services. And I talked a lot about that earlier today. But what do we do? So many are disengaging from treatment when they transition from child to adult services, resulting in discontinuation of treatment. And the outcomes of not being treated, as you can see, are severe. The outcomes of dropping out of treatment prematurely are likely to be severe as well. How can we avoid it? I mean, there are loads of questions here still. We can initiate treatment at any age, but if we're to prevent negative long-term outcomes, we need to intervene earlier in the process. Too many young people are slipping through the net and don't receive the treatment they need. How do we address this? And we thought about this earlier today as well. Even with treatment, 28% of outcomes don't improve. So how do we improve treatment outcome for problems that seem more resistant to standard treatments, like the antisocial, like the occupational treatments? Maybe we need specific treatments, like R&R2. More need to be developed, and in particular, I think occupational treatments need to be developed, because there are barriers to employment for young people with ADHD, but what are they? We've got to stop young people moving from classroom to courtroom. I mean, not everyone's moving to the courtroom. They're moving from classroom to unemployment, to life in, a life of feeling unproductive and unhappy. How do we engage other agencies to identify and support and manage young people with ADHD? This is not just about the healthcare system. This is about the criminal justice system. This is about the educational system. It's about the occupational system. We have to join people up. We've got to involve everybody. Well, we need to invest and save. It's a treatable condition. That's the thing everyone forgets. There is a treatment for ADHD. We need to invest in early intervention programs. We need to invest in services. We need effective employment schemes. Whitepaper Recommendation 1, increase informed awareness of ADHD in schools, in the workplace, in the criminal justice system, and in broader society. Recommendation 2 was improve access to early and accurate diagnosis of ADHD in schools, in the workplace, in the criminal justice system, and in broader society. Recommendation 3 was improve access to ADHD treatment, care, and support. Improve access with treatment guidelines, collaborative and integrated care pathways, and to monitor, review, and follow up. Recommendation 4 was to involve and support patient organisations. It's so important we listen to our patients. They have to be involved at every step of the process, be this policy debates, decision-making procedures, whether it's joint working groups and policy dialogue forums, whether it's patient-friendly guidelines, documents, information that can be easily accessed and read and understood by our clients, and also EU and national government funding. We really do need funding for these studies. So, encourage a patient-centered research agenda on ADHD, and this is going to require public funding and also dissemination of research results through our patients, through academia, and through the policymakers. So the 5 recommendations are not listed in order of importance. They're in a logical sequence. And the logical sequence is better awareness, better diagnosis, better treatment and care, better quality of life. And I think that these are things that we can all sign up to. And there are 2 crucial elements for the improvement of the existing support frameworks. And that's having very strong, organized ADHD patient organizations, also linking into Europe-wide patient organizations. We need more, and we need much more comprehensive and collaborative patient-centered research into ADHD. And they are the recommendations and the call for action that came out of the white paper. Nessa Childers, the member of the European Parliament, summarized and summed it up by saying, the fact that this expert white paper was endorsed by a variety of stakeholders makes the messages it contains even stronger. It is my sincere hope that this document will help to ensure better recognition and better management of ADHD by all stakeholders in the wider healthcare arenas, in schools, in the criminal justice systems, and in the workplace, in each country across the EU. I'm going to stop now. You'll be so pleased I'm going to stop talking. So thank you very much for your attention and for sitting still. And I'm particularly impressed with those of you who stayed still for all that time this morning and again came back for more punishment this evening. And this is the website, again, psychology-services.uk.com, where there's going to be lots of resources and information about training. Thank you very much, and I'm sorry I ran over.